Hello, everyone, and welcome to another episode of the Overcoming Chronic Illness podcast. My name is Brian Rade, and I'm a naturopathic doctor. And today I am joined by Angela Hoffman. Angela is a registered respiratory therapist and a certified respiratory educator, and she's also the founder of Navi Sleep Respiratory Solutions, which is she's based out of Sackville, New Brunswick, but they provide virtual care all across Canada. So it's a nationwide company. And normally I, record a little preamble before bringing my guest into the episode, but I was running a bit behind today. So Angela's here. We are just, right out of the gate. So welcome to the podcast, Angela. Thank you for taking the time to talk to me today. And could you please just let folks know about your history, and we'll get into the weeds of everything that you do.
Absolutely. Thank you, Brian. I appreciate you having me. As I've mentioned, any opportunity to talk about sleep and drive awareness is one I will always take. My name is Angela Hoffman. I am a registered respiratory therapist and a certified respiratory educator. I am also, as you said, the founder of Navi Sleep, founder and clinical director of Navi Sleep, which is a virtual sleep testing and consultation practice. Which basically, in plain terms, we help people figure out whether a breathing problem during sleep is behind how they feel, and then we help them navigate from symptoms to a proper diagnosis to a treatment plan that actually matches the root cause. So we do multi-night home sleep testing, and we work independently of any one product or device. So the plan is really built around the person and not the equipment.
Okay, so one of the reasons that I wanted to have a chat with you, in part because one of our mutual colleagues had highly, sung your praises and the services you offer. Is like, I need to learn more about this. But yeah, the multi-night home sleep sort of assessment or test, or sorry, what was the last word?
Yep, multi-night home sleep testing and sleep consultation.
Great. So yeah, could you? I'm the impression I was under after talking to our mutual colleague was that it was a lot different than your standard, like I'm going to go to the snore shop or equivalent and get an assessment done. And sorry, I'm just going to pause the recording for 1 second. I just have a knock on my door because I am at work. So just sorry, give me one quick second. I'm just going to pause.
Sure.
All right. Sorry, folks. Could you please tell us how a multi-night home sleep test differs from like a standard assessment at a snore shop or equivalent?
Right. So what we do, we use Health Canada approved wearables, and we do multi-night testing. So we do actually 7 consecutive nights of sleep testing. If there's one thing I've learned over the 23 years of being in respiratory care and sleep medicine, it's that sleep is not, there's variability from night to night in sleep. So a one night snapshot doesn't give us a full picture of somebody's sleep quality. So it's imperative, and especially since technology has improved, it's imperative that we're able to capture night to night variability. So we run 7 consecutive nights of sleep testing. Those sleep tests get interpreted by our sleep physician. And then once the results are returned to us, we sit down and we have a 45-minute virtual consultation to educate patients on their sleep, educate them about airway and breathing, and then review their sleep study results and formulate a plan to correct their sleep quality if there's a need for it. So multi-night is exactly how our platform is built. We see a ton of value in it, and it really does help us put the pieces of the puzzle together for patients.
Great. And so with those wearables, and I've never had the pleasure of having a sleep study done, so I'm a little ignorant, but I've heard some stories from folks where they're like, oh, like it was just wearing things that were uncomfortable, or it's like, oh, really interfered with my sleep, or heaven forbid I have to like go into like a lab or the hospital or something to like go to sleep, and it's like the worst place in the world to try to sleep. So what are the wearables like? Like what's the patient experience like with one of these wearables?
Yeah, these wearables have come a long way, and it's honestly done such a service for our patients because traditionally, the gold standard for sleep testing is a level 1 in-lab sleep study, and you can imagine you're rigged up to 1,000, what feels like 1,000 different leads, and you're sleeping in a foreign environment. So A, you can't really sleep in the position you'd like to, and B, you're in a foreign environment, so it's not a really great capture of what your real-world sleep looks like. Alternatively to that, there are home sleep tests, which are often They're often given out by CPAP vendors, and they're traditionally a one-night sleep study where you go home with the device. Again, less equipment than an in-lab sleep study, but still quite a bit of, chest straps, nasal prongs, finger clips, enough equipment that it can have an impact on someone's sleep quality. And where it's a one night, there's often this psychosomatic issue of knowing you're being tested. So your sleep quality isn't quite exactly as it would normally be. So wearable technology became Health Canada approved in the early 2020s. And we've been really fortunate. Along with the wearable technology has come the capability of doing multi-night. So the wearable technology honestly looks like your standard Apple Watch, and it has a finger clip attached to it. So that device is paired with a software that scores someone's sleep, and then our sleep physicians are actually able to go into that platform and diagnose from it. So the wearable technology has allowed for people to sleep in all positions, which is lovely. But second to that, it's allowed us to do the multi-night, so we can get, by the second or third night, we can get quality sleep that actually reflects what the patient is experiencing.
And if I had a patient who was like, oh man, like I'm just a really active sleeper and I'm thrashing all over the place, like do those finger clips come off very easily or they're pretty glued on there?
I mean, they're not tight by any means, but we rarely have issues with them coming off. The beauty in being able to do 7 nights consecutive is a bit of overkill, but it accounts for those nights where there may be poor data because somebody slept on their arm and perfusion's not great to the finger, or it slipped off. So within that 7 night period, we can often find 5 really good nights of data to work with.
And then in terms of like, the essentially like an Apple Watch with finger clip versus like rigged up to 1,000 cables or sensors or whatever, like what's the if say the in-lab study, notwithstanding all the logistical issues that really make it suboptimal in many ways, if that's like, the gold standard, um, is a wearable, like, is it 90% as sensitive and or specific? Like, what's the comparison, pound for pound?
Yeah, that's a great question. It's actually 97%
Wow, that's amazing.
accuracy in
Wow.
comparison to a level 1 sleep lab.
Wow.
So it's really, and that is in detecting sleep disordered breathing. When it comes to more complex sleep disorders, your level 1 in lab sleep study is always going to be the gold standard. But for common sleep disordered breathing, that's not complex. We've got a 97% correlation with in lab sleep studies,
Cool. That's pretty darn impressive,
isn't it?
I'd say. Um, okay. And so I guess kind of walking through the patient experience. So, they, reach out to your company, you send them the finger clip and the watch, essentially. Like, maybe you could just walk me through, like, so
Sure.
they email or call you, like, what's the start to finish steps that they would
Yeah. So most of our referrals are coming from medical. So GPs are referring, we've got dentists referring, and you can self-refer, which is lovely. You can self-refer for sleep testing through our website. Once you self-refer, the intake form comes into us, we contact you, and that's when the process starts. We have you fill out a just a really comprehensive sleep questionnaire so we can get a really good gauge on your subjective symptoms. And then we ship out the sleep testing device. It's return shipping is all included in the cost. So the device arrives, you have a 7 night window to test within. Some people choose to do 5 out of 7 nights, and that's fine too. I like a bare minimum of 3 nights. But once the testing window is closed, the device gets returned to us. Those studies get uploaded to our sleep physician who interprets the studies, and that's when our sleep consultant receives the interpretation and sets you up for a virtual consultation to discuss all of those results. Once the sleep consultation is complete, The patient gets a full comprehensive breakdown of their sleep study results and a summary report, and we also send it over to the primary care physician or nurse practitioner so that everybody is looped in to the study results and all discussions that were had. If there is a need for a prescription for treatment for sleep disordered breathing, we will request that prescription when we send the report into the primary care physician. Once we've got that prescription, we then refer you down the pipeline for treatment. So we don't do treatment. NaviSleep doesn't do treatment. We do diagnostics only, and we do consultation. That removes us from the treatment side of things so that we can have really beautiful, transparent, unbiased conversations about your sleep, your potential condition, and all of the available treatment options available to you. So that's backed by clinical guidelines, but we're also not just looking at clinical guidelines and how to treat sleep disordered breathing. We're looking at our patients through a lens of being a whole body, whole human. So we have to understand some of the barriers that patients might have to certain treatment options, some of the financial barriers. We have to look at all of it and give our clinical guidance on finding the right pathway that the patient can adhere to long term, because any treatment for sleep disordered breathing is not short term. It's a lifelong treatment, and finding the right treatment out of the gate and having patients fully informed and making fully informed decisions about how they'd like to treat shows that compliance improves automatically because the patient feels heard and they feel like they are supported in what best suits their lifestyle.
In terms of, and I know you folks don't offer treatments, but I mean, I think when most folks hear about, sleep disorder breathing, they're thinking, oh, it's probably like, a CPAP, or maybe they've heard of a BiPAP or BPAP or tomato, maybe. But are there other, what are some other avenues that are sometimes pursued? What are some other treatment options that might come up?
Right, there are a bunch, and there will be more and more treatment options as the years progress. But everybody knows about the gold standard for treatment, which is CPAP. CPAP is essentially just a pneumatic air pressure or a blower that blows air in and splints the airway open so that it can't collapse, and it reduces your sleep disordered breathing. I love CPAP. It's highly effective, but any treatment has to be the right patient, the right therapy for the right patient at the right time. And compliance rates with CPAP long term are fairly poor because patients aren't able to make informed decisions about how they would like to treat. They're kind of treated with a one-size-fits-all approach, and the reality is CPAP is not meant for everyone. Not everyone can tolerate it. So we do talk about CPAP quite often, especially with our moderate and our severe obstructive sleep apnea patients. But we also talk about oral appliance therapy, mandibular advancement devices, which are essentially mechanical splints. You put in a dental device at night and it mechanically splints the airway open by moving the lower jaw and the mandible forward. By doing that, what it does is it displaces the tongue and it tethers and splints the airway open mechanically by pulling the structures forward. So oral appliance therapy has been in the guidelines for years. It's not talked about very often because it is a medical device that's made by a dentist, and where dentists aren't medical doctors, they have to have extra education and extra credentials in dental sleep medicine to produce these devices, and they require a medical doctor's prescription. So those are all things we navigate with the patient and for the patient. But oral appliance therapy is effective, and patients are highly compliant with that therapy. So if we were looking at CPAP versus oral appliance therapy, we'd really have to see which one is most conducive to long-term success in that patient. And then other than that, we do positional therapy. We talk about orofacial myofunctional therapy, which is essentially, in layman's terms, we'll call it physio for the tongue and physio for the structures inside of the oral cavity. Because most often sleep disordered breathing's root cause is weakness in the structures inside of the oral cavity. So if we can strengthen those structures and allow those muscles to move and tether other structures open just by improving the strength of them and the position of them, or orofacial myofunctional therapy is highly effective, and it's wonderful for our primary snoring or maybe our mild obstructive sleep apnea patients. We also talk about nasal breathing optimization. We talk about proper breathing mechanics with patients. We give them all sorts of tips and tricks and tools to improve their sleep hygiene, put them into a good position for airway support, and then we find the right solution as a Band-Aid solution to treating the overall sleep disordered breathing. So lots of different options out there.
Yeah, I'm glad you brought up the orofacial myofunctional therapy because yeah, we do that in my household for a couple of my family members, a couple of my kids, and my wife and I do the exercises too because we do them along with our kids for optimizing compliance, and it's fascinating, so fascinating. I guess one of the questions I have, and maybe it was a semantics thing or I misheard or whatnot, but I thought that earlier in the chat you had said something about like, when there's sleep disordered breathing, then there's going to be essentially like a mandatory long-term treatment. And then like if there is, say a need for that physiotherapy of the tongue, and maybe arguably like related structures, because goodness knows some of those myofunctional exercises, like I really feel it on my cheeks and other places too. So there's like other structures too, one could argue. But long and short of it is are there cases where there's sleep disordered breathing, but then, with the right, say like myofunctional rehab, then a patient doesn't need, ongoing use of their oral appliance or CPAP or what have you? Like, can you actually rehab those muscles and get things fixed up?
You can, and I think it is semantics because with OMT, what we know is that if the habit isn't sustained, we will regress and go back to old habits if it's something we've been doing long enough. So for our pediatrics, often, if we're doing OMT with pediatrics, they don't really need to work at it long term. But for any of us who have had maybe some muscle weakness or breathing dysfunction for years, it's something we have to remain mindful about long term. Otherwise, we will also regress. We also need to be mindful about optimizing our nasal breathing and staying on top of that, because if we don't maintain the nasal hygiene and doing the things we need to do to optimize nasal flow, we will regress back to mouth breathing and the dysfunction that comes with it.
Does the nasal breathing optimization ever involve mouth taping out of curiosity?
I mean, I love mouth tape is something that comes up quite often. So nasal breathing optimization has to come before mouth taping. If we haven't optimized nasal flow, we shouldn't be taping the mouth. Nasal breathing optimization is mostly opening up the nose and getting people to use the nose the way it was meant to be used. The nose is a use it or lose it organ. So if it hasn't been used for a very long time, it takes time to convert the brain to using the nose, but it also takes time to optimize the flow because nasal breathing produces something called nitric oxide. Nitric oxide is produced in the parasinuses. So as you start to use your nose optimally, you will start to produce nitric oxide, which helps vasodilate and open up the nose further so that it becomes easier and easier to use. Before you can get to that stage, though, a lot of us need a little bit of a Band-Aid solution to help us optimize the nose. And what I commonly use with my patients is nasal dilators. Nasal dilators help splint open the first nasal valve, and it reduces the resistance we feel to nasal flow so that it mimics mouth breathing a little bit more, because the brain has to get adapted. If you've been mouth breathing year after year, you get adapted to the sensation of very little resistance to breathing in or out. As soon as you try to convert to nasal breathing, you'll feel that resistance. Not because it's not meant to be there, but because the brain has gotten so accustomed to a wide open mouth breathing posture. So nasal dilators help bridge that gap. We open up the nose with nasal dilators for anything like exertion or for nighttime use. And then we slowly wean you off that as you become more and more dependent on the nose to breathe. In the same breath, we train the tongue to stay up, suction to the upper palate, so that we can keep the mouth closed and we can maintain that closed mouth position at night. If we nasal breathe at night, but our tongue is weak and sits low in the oral cavity, we will often drop the mouth open just from weakness and revert back to mouth breathing. So it's kind of twofold. Start with nasal breathing optimization, then start strengthening the tongue. Once you've strengthened the tongue enough that you are able to maintain the correct position, so the posture of the tongue in the oral cavity, then you can consider mouth tape. But not until the tongue is strengthened so that we can ensure it's out of the way of the airway. Because if we tape a mouth closed and we have sleep disordered breathing, the primary defense mechanism when we have an obstruction in the pipe is to open the mouth to pull in more air or to blow out more CO2. We don't want to get rid of that defense mechanism because that's what brings us out of that obstructive event. So it's kind of there's a progression to it. It has to start though with nasal breathing optimization. And then the rest we kind of add on as that gets better.
So, what's the litmus test for whether there's optimal nasal breathing in the first place? Like, can you tell that from the multi-night home sleep test?
No, that happens on the sleep questionnaire. We ask a lot of questions about nasal breathing and nasal resistance and nasal trauma. Then the rest of that happens during the consultation where we can see the patient. First and foremost, we watch to see what they naturally choose when they're resting. And then we wait to see if there's dysfunction while they're talking. Are they able to lift the tongue up, the tip to mid to base? There's a few little assessments we do to determine if there's tongue weakness there.
Gotcha.
Our dental referrals will actually put in tongue restrictions, open bite. They'll put everything in there that we need, so we get even a better lens when they're coming from dentists because they're actually looking in the oral cavity, as opposed to most of our medical doctors who aren't always looking in the oral cavity when someone's talking about poor sleep quality.
Mm-hmm. And then maybe just one more note on the like kind of the OMT slash orofacial myofunctional therapy and kind of the maybe structural aspects of things. To what extent do you feel, or is it known? I'm not sure to what extent this has been researched at all, but like to what extent do you feel, or is it known that like certain types of orthodontic work could have an impact on oral myofunctional or orofacial myofunctional like dysfunction, and subtext like folks getting wisdom teeth hauled out, teeth removed or whatnot, just for cosmetic reasons, so the braces like kind of work better. To what extent would you say that's plays a role?
Yeah, I mean, thankfully, extracting teeth is less and less common now when there's less room. So teeth are extracted because there's crowding and there's no room for the adult teeth to come in. And orthodontics is leaning more in the direction of creating space rather than removing teeth. So by creating space, what they'll do often, especially when there's an airway concern, is they will expand the upper palate. Because we know the tongue needs to be suctioned to the upper palate in order to be pulled up and away from the airway so that it can't obstruct the airway at night. But what if the palate is so narrow that the tongue can't fit and it spills out over onto the upper molars? So orthodontics will actually, we have some airway focused orthodontics or orthodontists out there who will expand a palate to support the airway. Um, and that is primarily, again, with our pediatrics, because after the age of, say, 15 to 17, palate expansion in adults gets very difficult because that fissure actually fuses. And so palate expansion in pediatrics to support the airway along with OMT is actually the best approach to treating sleep disordered breathing in children, and would get to the root cause so that they don't end up as adults with sleep disordered breathing down the road.
Um, so just for maybe clarification purposes, like you've used the term sleep disordered breathing consistently throughout our entire interview so far, and notice that you haven't specifically said sleep apnea. So just in case folks are wondering, like, oh, are those synonyms or whatnot, would you mind just differentiating those terms for us, please?
Absolutely. I always use sleep disordered breathing because sleep disordered breathing exists on a spectrum. So on the far left of the spectrum, we have simple snoring. On the far right of the spectrum, we have obstructive sleep apnea. We consider obstructive sleep apnea end stage disease. There's snoring and there's upper airway resistance syndrome that are on the spectrum that come ahead of obstructive sleep apnea. So if we can start to capture patients that have just simple snoring or upper airway resistance, we can feasibly treat that form of sleep disordered breathing and hopefully not have them move into end stage, which is obstructive sleep apnea. And the biggest difference is obstructive sleep apnea is considered a medical condition because it includes the criteria in having obstructive sleep apnea is that when you obstruct, when the pipe caves in or something blocks the pipe, it has to be blocked for at least 10 seconds or more, and it has to create a drop in oxygen level by 3% or more. That's how you get a marker or a point that that's an obstructive event. And then we count how many times per hour is that happening. And that gives us a number called the AHI. Everybody knows, most people know in sleep about AHI. AHI is how many obstructive events that actually meet that criteria. So anything less than 5 of those events every hour is considered normal. Anything between 5 to 14.9 times per hour is considered mild. Moderate is 15 to 29.9 times per hour. And then over 30 times per hour, where you obstruct and drop the oxygen level, is considered severe. The other two conditions, snoring and upper airway resistance syndrome, they don't lead to oxygen drops because the airway is either only partially blocked, so there's still air and oxygen getting in, or the airway is blocked for less than, it's for a short amount of time and doesn't create the oxygen drop. The problem with snoring and upper airway resistance syndrome, though, is it is highly impactful to sleep quality. So even though it's not adding insult in the low oxygen, it's highly impactful to sleep quality, which then leads to less reparative and restorative sleep stages of sleep. So none of the conditions on the spectrum, none of them, they're not conditions you want to have, but if we can capture patients prior to them moving into the obstructive sleep apnea category, we can remove that insult of the low oxygen, which honestly leads to a slew of chronic illnesses and makes chronic illness very difficult to treat.
So I think that's a great segue into just talking about kind of symptoms to look at. So maybe we could, if you don't mind, kind of split it into two categories. So if we maybe talk about just sort of standard symptoms of sleep disordered breathing to watch out for. So someone listening to this, or if I'm chatting with a patient and kind of what should I be screening for in terms of like more of like what I affectionately call like my normie population. And then I'd like to also ask you about like what we might want to look for in patients who are dealing with complex chronic illnesses. So things like, fibromyalgia, chronic fatigue syndrome, really like, diffuse, severe autoimmune disorders, folks with neurological disorders like, say, MS or Parkinson's, or like, later stage, say, forms of dementia, things like that. So folks who are like, really, really, really quite sick and struggling with like really, notable health challenges. So I'm not sure if there would be a distinguishing line there. I'll leave it to your expertise, but if we could maybe talk about like the average patient population first, things to look for, and then if there is a distinction with the folks with complex chronic illness, I'd love to hear about that too. So I'll leave it to you.
Right. I mean, traditionally we look at sleep disordered breathing and we're looking for one type of patient phenotype. And I think when we think of obstructive sleep apnea, we think of over 50, male, potentially overweight, and loud snoring. So those are risk factors, and the snoring is a symptom. Waking gasping, waking with your heart rate racing, waking in the morning with a morning headache, sleepiness during the day. Those all fit into one certain category, but then there's all of these outliers which aren't your traditional phenotype, which actually make up a huge population of patients that are suffering out there. It's all of the patients who have maybe the symptoms are a little more mild, or they're not always linked to sleep disordered breathing or sleep even. So some of the non-traditional symptoms: brain fog, fatigue, chronic fatigue and exhaustion, nervous system dysregulation, the morning headaches. That one is typical for most phenotypes. We'll wake up with a morning headache if we've had sleep disordered breathing. Getting up to the washroom at night. That is something that until you're about over the age of 65, we shouldn't be getting up to go to the washroom, mostly because if we're cycling through the levels of sleep appropriately, we actually shouldn't be making enough urine to fill the bladder to have to go. So waking up to go to the washroom is a big one. Mouth breathing is a simple sign or symptom of sleep disordered breathing, because it's dysfunctional breathing and it's putting the structures in the oral cavity in the wrong position to support the airway, or a poor position to support the airway. Night terrors. Anyone who dreams about being suffocated or drowning, or anyone who gets up with night terrors, maybe they get up and they're racing out of the bedroom. That's a big one. People think night terrors are just emotional processing or brain processing of dreams, but they can often be precipitated by an obstructive or a sleep disordered breathing event. Squeaking. Some people don't snore, they actually squeak at night. So if a bed partner says you make this awful squeaking noise at night, that's cause for concern. Another big one is, and this one is particularly in women, we have a bit of a puff on exhalation. So if a bed partner notices that we puff when we exhale, that's restriction or obstruction at end of our exhalation. It's just a different timing of the obstruction, and can be, again, have a pretty big negative impact on our sleep staging. So there's a whole slew of symptoms out there. Everybody experiences this differently. I think the biggest takeaway is that not all people with sleep disordered breathing feel sleepy. Kids don't often feel sleepy, and women don't often feel sleepy, or even people under the age of 30 don't often feel sleepy. Sometimes they just feel dysregulated, foggy, or exhausted, wired and tired. That's a big one. Also, fasting sugars. If you're waking in the morning and your fasting sugars are elevated, we have to start looking at what might be going on during those sleep cycles. AFib, reoccurrent AFib is a big one. If you're, having difficulties controlling your atrial fibrillation, it could be that you've got sleep disordered breathing, which is compounding the issue. So there are a slew of different symptoms. I think the biggest thing is, insomnia. I want to mention insomnia. Insomnia is often a secondary condition that was developed because of sleep disordered breathing. So when the brain is consistently kicked out of its deeper levels of sleep because of sleep disordered breathing or because airway collapse, what happens eventually, and this happens predominantly in women again, is that we stop producing melatonin at the right time. We stop producing and setting ourselves up to actually be able to cycle into sleep, and we can develop secondary insomnia. So when someone has insomnia, it's imperative that we look at what's going on with the quality of their sleep before prescribing any sort of sedative. Because a sedative, if the condition underlying is actually sleep disordered breathing, or the root cause of the insomnia is sleep disordered breathing, when we add a sedative, what we're doing is we're taking away that person's defense mechanism in waking when they stop breathing. They then don't wake as quickly, and so their obstructive events last longer and have a bigger systemic effect. So those are, I mean, it's a myriad of symptoms, and it's everybody has different symptoms. It's more about putting the picture together and getting curious about sleep. I think just opening up the conversation around sleep and what quality sleep should look like and what someone's experiencing and measuring those against each other and then putting objective data on it is extremely important, because we might just be chasing our tails otherwise.
Hmm. Um, I just had a patient earlier today, and she was telling me that she's been sleeping better lately, like clocking more sleep hours for like the last, I don't know, month or give or take. And she's been feeling, and she's not taking like any sleep aids or anything like that. So I'm really not 100% sure why she's sleeping better. Um, but regardless, she's been feeling like just rotten like ever since she started sleeping more. She's like, she says like it takes until like noon before the sleep shakes off kind of thing. And I mean, that's just what you said about like, avoiding like sedatives and stuff like that. Like that stands to reason. I'm just wondering if that would be, I don't know, have you seen that like outside of like a, sleep aid sedative type, induced worsening fatigue type thing the next day? Does that ever happen? Have you seen anything like that before?
I have. I see it all the time. I think we have to distinguish between sleep quality and sleep quantity, because logging more sleep hours doesn't necessarily mean that you're logging the right quality sleep.
Mm.
So we should all be able to fit our sleep cycles into a 7 to 9 hour window, because we all need to cycle through our levels of sleep and do a sleep cycle 4 to 6 times per night in order to gain the right architecture to support quality of life, repair, restoration, all of the good things that come with sleep. So anyone who requires more than 9 hours, it's less of a bragging rights than it is concern for, okay, why are you sleeping more than 9 hours? Why are you capable of sleeping more than 9 hours? Is it because we have a quality issue?
Mm.
So we always have to look at sleep quality versus quantity, because quantity is easy to fix. If you don't have more than 7 hours, you can't cycle 4 to 5 times through your sleep cycles, because sleep cycles last about an hour and a half to 2 hours. It's different for everyone, but as we cycle through those levels of sleep, we have to do that 4 to 6 times. Anything less than 7 hours just isn't enough sleep time to fit those cycles in. Anything more than 9 hours indicates that there might be an issue with quality. On the flip side, if there's something that's been done, if there's been intervention to improve sleep quality, and a patient continuously sleeps more than 9 hours, they might just be in a rebound. REM has a rebound. It wants to capture and go back and get that REM cycle and really get what it's lost over the years. So oftentimes we can have this, even with CPAP, you'll put a patient on CPAP in the first week, they feel fantastic. By weeks 2 and 3, they actually start to feel worse, because their brain is trying to recapture what it's lost, and it's asking them to cycle back into sleep every time they wake in the morning. And so they're really quick to want to fall back to sleep. And it's not because they have an airway issue, it's because we fixed the sleep and now the brain is trying to regain what was lost.
Um, by any chance, are you aware of any studies that have been done looking at the incidence of sleep disorder breathing in folks with chronic fatigue syndrome?
Not off the top of my head, no. Chronic fatigue, I don't often. I find that most of the patients we're doing consults on that have chronic fatigue also have an underlying airway issue. So it's been very difficult to distinguish which one came first. If there's an airway issue that sits in the moderate to severe category, we have to guess then that that airway issue has been there for a number of years. If they have very mild or just primary snoring and chronic fatigue, then we'd have to look at chronic fatigue. But no, it's hard to distinguish between the two, especially when we pair that with perimenopause. Then it really gets blurred because there's a lot of symptoms of chronic fatigue that mimic that of perimenopause, but also mimic that of sleep disordered breathing. So filtering through exactly the root cause is always just the most important. If there is an issue with chronic fatigue, it's best to at least rule out airway so that you can focus on the root cause of the chronic fatigue.
Are you aware of like in your own experience or like aware of colleagues who have like seen cases of chronic fatigue syndrome, like say someone's had chronic fatigue syndrome for like, 5, 10, 15 years or something like that, and they've, tried a million and one things and then they, correct their sleep disorder breathing and that's what, cures that resolves their chronic fatigue?
I've seen it time and time again, um, especially in patients who might not fit that typical profile of someone with sleep disordered breathing. Maybe they're thin women. It's usually thin, narrow neck women, chronic fatigue, sleep disordered breathing, treat the sleep disordered breathing, give them back their sleep architecture, and now their chronic fatigue has essentially been eliminated and maybe misdiagnosed as chronic fatigue when really it was just poor sleep architecture.
Wow. Okay. That's
Hard to
amazing.
distinguish between the two.
Hmm. Um, and you mentioned, sleep disorder breathing in kids. What's the youngest age that uh, your the multi-night home sleep testing could be done on?
Yeah, 2 years and up.
Oh well.
Which even a 2 year old's tough to test, just because they're just a little less compliant at times in wearing the device. So sometimes we'll ask parents to actually slip the wearable on after they've fallen asleep.
Right.
So we lose some of the metrics that we like to rely on, like how long does it take them to fall asleep, their sleep latency. But 2 and up is, we have a pediatric sleep physician who interprets from 2 and up. So she'll do anyone from the ages of 2 to 16. And then once we hit that 16-year-old range, we can actually move into adult wearables because most often they mimic more the adult sleep stages and sleep architecture than pediatric.
Got it.
Mm-hmm.
And then I know there's, a growing number of folks who come into my practice telling me about like, oh, I've got my, X, Y, or Z wearable, and then it's telling me about like, how many hours of this or that I'm clocking for like my REM sleep and this and that. So if we call those like, shall we say more of like an over-the-counter wearable, like how does
Yeah,
that compare? Like if we,
consumer.
yeah, there we go.
Yeah, we just call them consumer wearables. And I have mixed feelings about consumer wearables, and it's again person dependent. If the consumer wearable is creating sleep anxiety, then it needs to be scratched right out of the gate because often people can get a little bit too focused on the data that a consumer wearable is producing. Accuracy wise, I mean, we can't use them to diagnose by any means. Their data sampling rate is just too slow, but we can use them to trend. So if somebody wears one of our Health Canada approved wearables, but also wears their consumer wearable on the same night, we can use that data to trend against their consumer wearable and trend it long term. But I find more often than not, it becomes a source of sleep anxiety, which further compounds the sleep issue.
And then Is there any, like, do folks have, is it possible to have like private insurance coverage to cover your services? Or is there,
So our services are covered at 50% by private insurers. It depends on the policy. It fits under diagnostic lab fee for basically respiratory arrhythmias is what it goes under. It really depends on the insurance policy. We don't do any direct billing ourselves. Patients pay up front and they submit. They're always approved by health spending accounts, which is nice. And then any of the treatment options, most of the treatment options that we refer down the pipeline for are covered by insurance. So sometimes it's costs to get a really good objective study and an unbiased consultation, but it sends you down the right pathway for treatment, which is the most important part of all of it, is understanding the condition, being educated and aware enough to know what you're able to tolerate long term, and rather than just being hit with a one size fits all approach to treatment.
and are you open to talking about the cost on the interview or?
Yeah.
Okay,
Yeah.
what's the cost?
So when we do return shipped devices, our full fee all in is $330. That includes the 7 night study, the shipping, the interpretation, and the consultation, and all of the communication with the primary care physician after the fact. So $330 all in. We do have another program. It's called the ownership package, which patients will actually purchase their own Health Canada approved wearable, and they can monitor their their sleep long term. So we run yearly studies, annual studies on these patients to trend their sleep data over time, especially when we've intervened when they've gone through intervention for sleep disordered breathing. It allows us to put that same objective data post treatment and gives us a really nice apples to apples comparison over time. So the ownership package is $499, includes the exact same service, but you actually get to keep your wearable long term and run an annual study. And our annual studies, patients to do another 7 nights and have a 30-minute consultation, that's $150. So for $150, we have patients doing, some of them do it every 6 months just to keep a finger on the pulse of their sleep health, and others do it annually. But where we spend a third of our lives in a state of sleep, it's something that we really need to know what's going on. We really need to protect and create a container around that time, because there are so many functions that happen during that sleep period, during that 7 to 9 hours. So keeping a finger on that pulse is important and can really allow for intervention for other chronic disease that might creep up. Before it's become an issue, we can actually intervene. So yeah, ownership package or the rental package are the two options for testing and consultations with us.
Great. Yeah, that seems very, very reasonably priced, Angela. That's really great to hear. I was expecting
Yeah,
a higher price tag, so that's very, very pleasing to hear.
wonderful.
That's very like accessible for not everybody, of course, but a lot of folks, I think. That's great.
That was the goal. The goal was always to have community impact. We learn these things and we know so much about them. We become experts in something. And to me, it's our duty to then share that knowledge and make things accessible to others. So that we just wanted to remove the bigger financial burden, because the flip side is those people who choose not to get the study done and not pursue treatment because of financials end up probably paying more out of pocket down the road for co-pays for other meds for chronic disease. So to me, it's preventative money spent rather than reactive care after the fact.
Yeah. Oh, that's wonderful. That's great to hear.
Yeah.
Well, Angela, I know our time is winding down. I need to get home to my wife and kids, and I'm sure you have things to do too. So I'm glad we had this chat. Thanks so much for taking the time to chat with me today. Would you mind just sharing with folks, and I'll put it in the show notes, just where your website, and then if there's any social media or other resources that you like to share, I'm ready.
Sure. Yeah, so if anyone's looking to get sleep diagnostics and consultation completed with us, you can go to our website, which is www.navisleep.com, and that's NAVI sleep.com. There's a self referral form. You can directly submit your self referral online, and then we'll contact with you within 1 to 3 business days. And then we have an Instagram account and a Facebook account. You can contact us through DM or you can private message us there, and we'll put you through the same process, same sleep questionnaire, and offer you either the ownership program or the rental program, whatever suits you.
Great. And the Instagram and Facebook handles, are they some version of Navi Sleep or?
Yep, Navi Sleep underscore Canada for Instagram.
Okay.
And then just search Navi Sleep and you'll find us on Facebook.
Wonderful. Great. Well, thank you so much again for taking the time to chat with me today, Angela. It was a real pleasure. I learned a lot. Knew some things about sleep disordered breathing, but not as much as I know now. So thank you so much for sharing that. And yeah, really appreciate your time.
Wonderful. Thank you, Brian. I appreciate it.
Well, my pleasure. And thanks, folks, for tuning into this episode of the Overcoming Chronic Illness podcast. We hope you enjoyed it. And probably should have mentioned earlier in the episode, but none of this was to be construed as medical advice. This is all for informational purposes only. So, of course, I don't think it really gave any medical advice at all, anyways. But yeah, please talk to your healthcare provider to get medical advice if you need that. And yeah, thank you for tuning in, and please stay tuned for the next episode.